Teresa, thank you for the opportunity to present our next speaker. Before I do that, again, I just want to congratulate you, the three of you. What an awesome day. The breakout rooms were lighting up. I could hear all the conversation occurring, and I know all the hard work you guys put into this. Congratulations. Another amazing year. So you don't have to be a physician caring for patients with lymphatic disease for very long before you start hearing the stories. The stories of frustration about coverage. It could be coverage of garments, it could be coverage for therapy, or even coverage for surgical lymphatic operations. And with that lack of coverage comes a lot of frustration and strife. And in 2018, I remember at that time, the LTA was very strong, and it continues to be, going through Congress to try to provide coverage for garments. But there really wasn't a movement that I could see happening on the surgical side. And so in 2018, alongside the Beth Israel Deaconess Medical Center, the Boston Lymphatic Center approached Blue Cross Blue Shield Massachusetts for an opportunity to sit down and have a conversation about surgery for patients with lymphatic disorders. I still remember traveling to the John Hancock building right here in downtown Boston with our delegation from BI, and we were met with a delegation from Blue Cross Blue Shield, led by their senior medical director, Ms. Desiree Otenti. I still remember we were given the opportunity to give a 1-hour presentation on what we offer as well as the data, and they followed with a 1-hour Q&A. I still remember driving home that night, and I told the delegation from BI I had never received such diligent questioning as I had that day, and it really was led by Ms. Desiree Otenti. She had read up and learned so much about lymphedema. I was astounded. I was asked questions that had never been asked, even in an academic setting with lymphatic experts. After that meeting, Ms. Otenti approached the Boston Lymphatic Center to sit down and continue that conversation. Not only is she diligent, but she is a listener, and she listened. She had no problem pushing back, and over time, over the course of 18 months, we came to some common ground, and we passed the policy 037 in the Blue Cross Blue Shield Massachusetts policy, and I believe and do believe it's still the first and only policy in the United States that exists for coverage of lymphatic operations. I do want to give a shout out, an important shout out, to Dr. Anna Rose Johnson, who's currently a plastic surgery resident at WashU, who is my research fellow at the time, who really did a lot of the hard work to fill the evidentiary gaps that Ms. Otenti had identified. And not only did we work together to pass that policy, Ms. Otenti continued to engage with our center so that just this week, we published a manuscript in our main journal, Plastic and Reconstructive Surgery, outlining how we came to this policy. And we did that because we want other institutions around the country, around the world, depending on the healthcare system, to use this as a model for how to move forward to get coverage. Desiree, Ms. Otenti Desiree, I'm going to call her Desiree. She has taught me so much about policy. She has become a friend. This year, she is awarded the 2021 LE&RN Impact Award for what she has done to push policy and coverage forward for patients living with lymphatic disease. With that, it's an honor for me to present Ms. Desiree Otenti.
Hello, my name is Desiree Otenti. I'm the Senior Director for Medical Policy at Blue Cross Blue Shield of Massachusetts. I'm also a nurse practitioner by training. Today, I'm going to be talking to you about how to work collaboratively with your health insurance company to more easily navigate the system. First, I'll be talking through some Health Insurance 101 topics to level set some key terms and concepts you'll need to understand for the rest of the presentation. Then I'll talk about medical policies and how they're created, and I'll end with some tips on how to navigate the insurance system in a supported way. Although I work for Blue Cross Blue Shield of Massachusetts, I'll be speaking more generally as I know this audience is from all over the country and likely has many different insurance plans. First, a little about Blue Cross Blue Shield of Massachusetts. Blue Cross Blue Shield of Massachusetts is the largest not-for-profit health plan in Massachusetts. We cover about 2.9 million lives, about 780,000 of which are out of state. We're part of the Blue Cross Blue Shield Association, which is 36 independent Blue Cross Blue Shield companies. And together, we insure about 1 in 3 Americans. Now I'm going to review with you some concepts you need to know to better understand how insurance works in general. Now, the core of insurance is risk management. If you think about car insurance or homeowners insurance, you're paying money to mitigate your risk of a high-cost catastrophic event, like a crash or a fire. Health insurance is a little different because the money paid not only goes for risk mitigation of unexpected events, like a broken arm or sudden illness, but it also pays for routine healthcare like primary care visits and mammograms. That's like car insurance paying for gasoline, or homeowners insurance paying for your fridge if the old one broke down. Health insurance is just a different type of insurance and works differently from the rest of the industry. The term fully insured is when the insurance company holds all the risk. The term self-insured is used when a big company, very big company, decides to hold financial risk and just uses the insurance company to help manage claims and other administrative tasks. Healthcare premiums are the dollars paid from your paycheck and from your employer on your behalf. And that money goes to health maintenance, like vaccines and yearly exams, and risk mitigation. What health insurance companies can do with those premium dollars is highly regulated and varies from state to state. In Massachusetts, where we're all nonprofits, at least 90 cents on every premium dollar has to pay for medical care. The 10 cents can cover administrative costs, but we basically all compete on that dime. So we're incentivized to try to use, say, only 5 cents for administrative costs. We're also regulated on how much money we can hang on to for covering healthcare expenses. If we hold on to too much money, we have to give some back. So let's say we set premiums too high and collected way more money than necessary. Then we have to give some of that money back to the employers or the members. On the flip side, we have to have enough money on reserve for at least a few months in advance, or we can't stay licensed. So it's a tightrope we're walking when we set premiums each year. We can't set them too high and we can't set them too low. Cost sharing is a term we use for the money you have to pay out of your own pocket on top of the premium dollars I just explained. It's that $25 copay or the co-insurance on a service or that deductible payment. It's your employer that sets what those cost shares should be. Now, I often get asked, why do we have cost sharing in the first place? What's the point? Well, one reason is to give transparency to healthcare costs overall. When you have to pay a percentage of the cost, it makes us pay attention to what the costs are overall. You might shop more, say, for when you have the choice to choose different providers. Another reason is something called moral hazard. This is a concept: if something's free, you're going to use more of it. So as an example, think about when you go to a buffet. When you pay a fixed price, it's much more likely you're going to waste food. When you go out to dinner and pay for each plate, you're more likely to order only what you need. And the same concept applies to healthcare. If you have to pay $25 every time you see your healthcare provider, you're less likely to visit that person when you don't need to. Now, what I'm describing to you is an overall concept. We know that there are plenty of times when you have no choice and you need to see your provider, either one time or frequently. And there are certainly exceptions to what I'm saying now. These are just some of the concepts that the insurance industry has to take into account. There's also something called an out-of-pocket maximum. That's a cap on how much you have to pay per year through cost sharing. If you hit your out-of-pocket maximum, you should not be responsible for any additional healthcare charges. Next, we have benefits. Now, those are the services in your health insurance contract that are considered covered by the premium dollars. Different states have different rules here, and the Affordable Care Act, or ACA, is a federal law that determines some broad categories that have to be covered. So for example, maternity care has to be a covered benefit. Your employer can add or subtract benefits, especially if they're self-insured. Those are often referred to as riders. It's always important to understand if your company, your employer, is fully insured or self-insured, and what riders might be in existence that add or take away benefits for you. Finally, there are different types of products that layer on top of all of this. These are the terms you've heard of before, like HMO and PPO. We call them products. Employers pick which products they want to offer their employees. The difference between each product is usually how much risk the individual has versus the company or insurance plan. So for example, if you have a product that has a low premium coming out of your paycheck every month, your cost share amounts are usually higher, meaning higher co-pays, co-insurance, and deductible. And this is because you're holding more risk as an individual. Products with a higher monthly premium payment usually means you're paying more money for the insurance company to hold more of your risk. And that tends to balance out with lower cost share amounts. The more risk any insurance company holds for you, the more expensive it will be. And that holds the same for car insurance or homeowners insurance. In summary, payers manage other people's money in a highly regulated environment and compete in the nonprofit world on cents on the dollar. So when you're managing other people's money, you have to step back and look at populations instead of individuals. And you ask, what works best for most people most of the time? If there are multiple choices with the same clinical outcome but different price tags, we would ask, which service brings the best value for the dollar? And think about all the services there are out there and all of the products, from lab tests to pharmaceuticals to surgeries to devices. It's a lot to sort through, trying to bring value to the people who are asking you to spend their money wisely. And that's where medical policy comes in. We use clinical trials to ask, does this service, this drug, this surgery, this you name it, actually make the patient better in a measurable, durable, and meaningful way? And how well do the clinical trials prove that? Are there established alternatives? Are those safer, more effective? Now, if the answer to all of these questions is, yes, this thing is amazing and it really helps people and it's proven in the science, we consider that service to be medically necessary. If the answer is anything short of that, if it's, we're not sure, or there are no studies, that service is investigational. If the answer is, no, it's definitely not helpful, which is rare to see because who usually publishes studies like that, but it happens on occasion, those services are considered not medically necessary. The clinical trials we rely on most are called randomized controlled trials. That's when you take a large number of people with the same condition, randomly divide them into at least two groups, give one group the thing being studied, and give the other a placebo. This works best when neither the patients nor the researchers providing the service know who's in which group. That's called a double-blinded study. Depending on what you're studying and the condition you're trying to treat, it's not always ethical to do a study this way. It's also really hard to double blind for something like a surgery. So not all clinical trials can be this gold standard of the randomized controlled trial. But every compromise you have to make in your study design away from the standard introduces uncertainty as to whether or not the thing being studied actually caused the health improvement. Sometimes these things happen by chance. When it comes to lymphedema treatment, such as debulking, lymph node transplant, bypass surgery, if you take the studies that are currently available and bump them up against this framework for evaluating clinical trials, there remains too much uncertainty about whether or not those treatments caused an improvement in health outcomes. Now, this doesn't mean that they don't work. And if you had one of those surgeries, it doesn't mean that you personally were not helped by it. What it means is that on this population level, more studies need to be conducted to prove scientifically that these procedures improve people's health. And that's why you see some insurance companies consider these procedures to be investigational. However, there are times when a medical policy team from the insurance company can work collaboratively with their local academic medical center or other experts to look at data outside of what has been published, or to apply clinical judgment in areas where the evidence might point to something promising. In those cases, you'll see more variability in insurance coverage like we do for the surgical treatments for lymphedema. As more research continues to be published on lymphedema, as the condition receives more attention from the medical community to better diagnose, treat, and create standards of care for lymphedema, you will see more insurance companies start to cover more services. I'll give you another example to help explain this point. There's a device, I won't name which, for treating migraines on the market. When you look at the clinical trials for that device, the people who got the placebo did more or less the same as the people who had the real device. So on a population level, the science does not show that the migraine device helps most people get better most of the time. Now, I know someone who paid for this device himself. He uses it frequently and says it helps him a lot. And I had to say to him, yes, that very well can be true for you. But if we can't figure out who else could be helped by this device, we can't apply your experience to the entire population of people who get migraines. We need more clinical studies to figure that out. Okay, so let's put everything together now with some examples. Let's say you're trying to figure out whether or not a compression garment is covered. The first thing you need to know is whether or not you have the benefit for that garment. You need to review your benefits. This can also be referred to as a subscriber certificate. It's a pretty long document, but it's supposed to be written in such a way that anyone could understand it. Now, the benefit document doesn't always get that granular regarding specific items, so you might not see the thing that you're looking for very specifically be named in your document. Usually it's a more general statement that certain types of equipment aren't covered, or certain types of surgery. On top of that, you would need to see if there's a medical policy on the topic, outlining which medical conditions are appropriate, say for the compression garment. The main audience for a medical policy is the medical community. So it's usually helpful to print out a copy of the policy, bring it to your provider, and ask how and if it applies to you. If I've lost you already, that's okay. And it takes us to our next bullet. Call your insurance company. It's their job to help you navigate this stuff. You might have to call more than once. And because these questions are pretty specific and clinical, you might need to talk to a specialized team. But it is their job to help you understand what's covered, what isn't, and why. You might consider requesting case management services through your insurance company if you qualify. Case managers or care managers are usually licensed RNs who understand more complex clinical care and can help you navigate both the insurance system and the hospital system you might be working with. And it's okay if you already have a case manager you're working with, say from your provider's office or through your hospital system. You can have one at the insurance company too. So let's say you called your insurance company, they helped you understand that the compression garment that you need is a covered benefit and your medical condition qualifies for coverage. We're taking the happy path. You want to make sure that you're getting the garment from an in-network provider. You can figure that out either by asking the provider themselves if they're in network for your insurance company, or you can ask your insurance company for a list of in-network providers for the service you're looking to receive. That being said, as you well know, lymphedema is a relatively rare condition, and there will be variability by insurance company regarding how well they understand and manage lymphedema. So it's also important to understand your rights as a member. If your provider is recommending services for you that are not covered or have been denied by your insurance company, there are different types of appeals process where you can state your case again to ask for coverage. The rules around how appeals work are different from state to state, but in general, depending on whether or not you've already had the service, there are different types of appeals you can go through. Your medical provider can also appeal on your behalf, or you can appeal yourself. Another time where calling your insurance company is going to be very helpful for this. They should be able to walk you through the steps on how to do it. At the end of the day, even though it might not always feel like it, you are a valued member to your insurance company, and they do want to help you. But sometimes it takes some conversations, and the process can end in services being denied. I'm not going to pretend that if you try hard enough, things always get covered. We know they don't. But hopefully, I've helped you understand why things are structured, how they're structured, and why things work the way they do today. And my main tip, which is granted fairly obvious, but very important, is reach out to your insurance company. Hopefully, by doing that, you'll be able to find some additional support on your treatment journey. Thank you very much for attending my talk today.
Thank you so much, and it's so nice to meet you. Meet you, Desiree. Desiree is there. Yep. Oh, hey, Desiree. Nice to meet you. This is Kathy Holly. It certainly generates a lot of questions from all of us across the country. One question was, let me get to it. How can we tell if our insurance company is fully or self-insured?
The easiest thing to do would probably be to reach out to your HR department in your own company and ask.
Okay. All right. And then at what point in our process of trying to get approval do we have to engage? Should we engage with our employer about them helping us, or is that only if they're self-insured that we reach out to them?
Usually it's mainly if you're self-insured because they have more leeway over coverage, although I'll say that most HR departments don't like to make exceptions. They want to understand why things are covered or not. They might decide to make an overall rider that could apply to anybody in the company, but usually they don't try to make single exceptions for one person in particular.
Okay. Someone reached out and said that they, for the life of having lymphedema, they had an insurance company coverage that paid for, covered their garments 80%. And then recently in the last few years, their employer changed companies. Now they have no coverage whatsoever. It's obviously that's something that many of us have faced. Do you have any recommendations for that as how we approach that with this new insurance company?
So I think the first step would be to reach out to the HR department. They might not have any idea that something like that has happened. So the more vocal you can be about it in terms of helping them understand the importance of that coverage, understanding again if they're fully insured or self-insured is going to be very helpful. The next thing you would do is reach out to the insurance company and find out why. Is there no benefit for a compression garment? Is it that there's no policy for coverage? Understanding that piece is going to be very important to understand how to navigate the next steps in terms of individual consideration, requests, and appeals.
Okay. And considering an appeal process, who actually reads the appeal? Is it a clinician that is familiar with lymphedema or someone else?
So depending on the insurance company, there may or may not be someone on staff in-house who's familiar with it. So on the first review, you may or may not be having that reviewed by someone who is a specialist or has specialized understanding about it. They are all physicians and well-trained and can learn about new topics very quickly. So it's not like they're not going to have any clue whatsoever about what it is. But typically what then happens is it gets either sent out if they don't have someone on staff, or it can be sent to an external company that has someone who specializes in that particular field that's being requested to review as either a secondary or a tertiary review.
And there are a couple of questions about Medicare coverage. This is from Barbara. Oh, hi, Barbara. Can you talk about Medicare coverage and the state of coverage currently?
So that's not my specialty. Unfortunately, I work in commercial insurance. What I do know is that Medicare operates with a few different principles. So they have something called national coverage determinations, which are policies that basically apply to any Medicare recipient across the country. And then they have local coverage determinations, and those are managed by different companies. We call them MACs, Medicare. I'm blanking on what the acronym stands for, but we call them our local MACs. And they have physicians on staff and other medical experts to make policies for regions. So to understand what's covered for you, you have to go to the Medicare website and navigate to find either the LCD or the NCD that potentially applies in this space. I'll be honest, I don't know if they have one for either surgery or compression garments.
Okay.
And that's where you'd start.
Okay. Someone has reached out and asked, can we get a link or a reference to the policy 037 that we're able to review ourselves?
Sure. So on Blue Cross Blue Shield of Massachusetts website, all of our medical policies are publicly available. The easiest thing to do actually is just to Google BCBSMA policy 037 and it comes right up. But you can also find it on our website.
Okay. Have you, I'm not sure you can answer this. Have you has Blue Cross Blue Shield been contacted, of Massachusetts, been contacted by other states looking at this policy and considering it for their coverage?
Yeah, so I've been asked by several policy directors at different insurance plans how we came up with this policy, what was the research we looked at, why, what were we thinking about. Whether or not they plan on making any changes isn't something I can speak to, but there has been a lot of interest in the policy.
Great. Did you have another question about that? Was there another one?
One just came in, Desiree. Thank you so much. So in the state of Massachusetts, we understand that lymphedema garments for lymphedema are covered by the state of Massachusetts for breast cancer patients. But then you run into a situation where the insurance company will deny it. What would the patient do in that situation?
So this is an important understanding about the fully insured and self-insured piece. If they're self-insured, state laws do not apply. Only federal laws do.
Oh, wow. That's
So
really
self-insured state laws do not apply.
That's correct.
Okay. Huh.
That's so interesting.
But federal laws do.
And unfortunate. Yeah.
Okay.
Oh, but the federal laws would at that point. Okay.
Yes. Mm-hmm. So that's why it was very important for the ACA to have, what I said in my talk, special pieces in there to cover, say, maternity, because there were self-insured accounts that carved it out entirely and didn't cover any maternity care whatsoever. So you'll see certain protections in those federal laws, and those apply to the self-insured accounts.
Oh, that's great.
I think our time is up.
Yeah.
Is that about right?
Yeah.
Okay. No, one question I have, may I have your home phone number so I can call you? Please. Thank you so much. It has been a pleasure meeting you and having you join us today.
Yeah. Thank you,
Thank you
Appreciate
very
your
much.
time. Okay. Bye-bye now.
Bye.